Imagine a child, they just drop their pencil, right? They stare blankly at the chalkboard for maybe 40 seconds, and then they just pick it up and go right back to writing. Like time never even stopped.
Right, yeah. And most teachers would, they'd just call that daydreaming.
Exactly, daydreaming. But neurologists call it an absence seizure. And today, we are sort of tearing up the textbook definitions of seizures to build something much more valuable for you.
Because the textbooks can be pretty dry, honestly.
Totally. So whether you're a clinician brushing up or maybe a caregiver or just someone who is fascinated by, the sheer complexity of the human nervous system, this deep dive is designed to give you a real-world pattern recognition toolkit.
Which is so crucial.
Yeah. We're moving beyond this idea of a seizure as just this chaotic, unpredictable event. We really want to look at the specific mechanics of what happens when the brain's electrical grid just, malfunctions.
And doing that requires us to rely really heavily on semiology.
Right, semiology.
Yeah, which for anyone analyzing these events, semiology isn't just about, documenting a list of physical movements on a chart. It's actually an act of reverse engineering.
Like working backward from the symptoms.
Exactly. By observing these highly specific outward manifestations, so things like posturing, the sequence of how muscles are recruited, the autonomic signs, we are essentially reading a topographical map of the brain's internal architecture.
Wow, okay.
The outward physical pattern tells you exactly where that localized cortical misfire started and how it propagated across different neural networks.
Okay, let's unpack this. Because when I look at the sheer variety of semiologies we have in the source material today, I don't really see that cliche, thunderstorm in the brain analogy that gets thrown around all the time.
Yeah, the thunderstorm analogy is a bit oversimplified.
Right. Understanding these different seizure types feels much more like diagnosing faults in a massive, hyperconnected electrical grid.
That's a great way to put it.
Like, sometimes a single transformer blows and it just takes out one neighborhood. But other times, you get this cascading failure that blacks out the entire eastern seaboard. And the sequence of that failure tells you everything you need to know about the grid's vulnerabilities.
I mean, that is a much more accurate framework. The propagation of the electrical failure really is everything. And so if we want to calibrate your pattern recognition toolkit, the most logical baseline to establish is that complete cascading grid failure.
The big one.
Right, the generalized tonic-clonic seizure.
Which is the one most people immediately picture when they hear the word seizure, right?
Oh, absolutely. It's what you see in the movies.
Yeah, but looking at the clinical breakdown in the sources, the outward chaos of it actually masks this very rigid underlying four-phase progression. It almost operates like, biological algorithm.
It does. It is remarkably consistent across different patients. And that sequence usually initiates with phase 1, the aura.
Okay, the aura.
Now, it's really crucial to understand here that an aura isn't merely a warning sign or some kind of psychological premonition. Biologically speaking, it is the earliest manifestation of the localized seizure activity right before it spreads.
Wait, I want to challenge the timeline on that. So is the aura a precursor to the seizure, or is the aura literally just a focal seizure that hasn't generalized yet?
It's the latter. The aura is the seizure.
Oh, wow. Okay.
Yeah, it's the patient's conscious experience of that initial localized electrical discharge. And because it is so localized at first, the symptoms are incredibly varied.
Depending on where the spark is, basically.
Exactly. Depending on which cortical region is sparking, the aura can be visceral. Like, you might get this rising epigastric sensation in your stomach.
Like dropping on a roller coaster.
Kind of, yeah. Or it can be sensory, producing phantom olfactory inputs like smelling burnt toast. Or it can be autonomic. The key is that the patient is fully experiencing this initial fault in the grid, completely aware, right up until the discharge overwhelms the inhibitory neurons and spreads across both hemispheres.
And once it crosses that threshold, the entire system just locks up. Which brings us to phase 2, the tonic phase.
Right, the rigid phase.
And this hits fast, right? Usually lasting only about 30 seconds. The skeletal muscles go into this massive, sustained spasm. But looking at the peripheral symptoms, it's a systemic cascade.
It really is.
You're seeing extreme pallor, the pupils dilating, the eyes deviating, and, often a total loss of bowel or bladder control. But there's one specific detail in the sources that I think gets widely misinterpreted by bystanders.
The vocalization.
Yes, the shrill cry.
Oh, yeah, that is deeply unsettling for anyone witnessing it, largely because, our human instinct is to interpret a scream as a conscious expression of severe pain or terror.
Right, but the patient has already lost consciousness by the time that sound is produced.
Yeah.
Right? So if they're entirely offline, how is the vocalization even happening?
It comes down to purely mechanical forces. So during that massive muscular recruitment of the tonic phase, the laryngeal muscles violently spasm, which essentially locks the vocal cords.
Yeah.
And simultaneously, the diaphragm and thoracic muscles contract really rigidly. So you have this massive volume of air being forcefully expelled from the lungs right through a suddenly narrowed, rigid airway.
So it's not a conscious scream at all.
Not at all. It is the physiological equivalent of squeezing a bellows through a whistle.
Just air being forced out of a rigid pipe.
Yeah.
Understanding the physics of that actually strips away a lot of the terror for a bystander. You aren't watching someone in agony, you're just watching a mechanical override.
Exactly. It replaces that fear with understanding.
Which brings us to the shift from phase 2 to phase 3. So after about 30 seconds of that rigid tonic extension, we move into the clonic phase. The continuous tension breaks into rhythmic, alternating contractions.
The jerking movements.
Yeah. But neurologically speaking, why does it switch from a solid lock to a rhythmic jerk? What changes in the brain?
So that shift from tonic to clonic is actually a fascinating glimpse into the brain's internal defense mechanisms.
Really? How so?
Well, during the tonic phase, you have massive, unopposed excitatory signaling. And this is primarily driven by the neurotransmitter glutamate. So the brain is just flooded with excitation.
There's all gas, no brakes.
Right. But the central nervous system has inhibitory networks, heavily reliant on GABA, and they are fighting to reassert control and suppress the misfire. So the clonic phase, that rhythmic jerking, is basically the physical manifestation of a neurochemical tug of war.
Wait, so the tension is the glutamate firing, and the release is the GABA temporarily slamming the brakes just over and over again.
Exactly that. Excitation, inhibition, excitation, inhibition. And as the inhibitory networks gradually gain the upper hand, the jerks become less and less frequent until the electrical storm is finally suppressed entirely.
Which drops the patient into phase 4, the postictal phase, the recovery period.
And it is a tough recovery.
I bet. The sources note profound exhaustion, confusion, semi-purposeful autonomic fumbling, and complete amnesia of the event. And honestly, this makes total sense. I mean, the metabolic demand of that neurochemical tug-of-war must be astronomical.
Oh, the cellular batteries are completely drained.
But the transition out of this violent motor phase leads to a highly specific diagnostic trap that I really want to cover. Let's talk about Todd's palsy.
Yes, this is a critical finding to recognize in the postictal period. Occasionally, following a seizure, the patient will present with a transient focal weakness or even complete paralysis in a single limb.
Wait, if someone is brought into an emergency department with a paralyzed arm and profound confusion, and let's say they live alone, so the seizure itself was totally unwitnessed, my first assumption, and likely the assumption of most triage nurses, is a stroke.
It looks exactly like a stroke on the surface.
So if the visible deficits are identical, how are medical professionals supposed to distinguish Todd's palsy from an acute ischemic event without just, waiting around to see what happens?
Well, what's fascinating here is that it hinges entirely on understanding the underlying cellular mechanism. See, a stroke is an ischemic event. A blood clot blocks oxygen, which leads to actual tissue infarction and cell death.
The tissue actually dies.
Right. But Todd's palsy, however, is a problem of metabolic exhaustion. During the seizure, the specific neural pathways controlling that limb fired so rapidly that they completely depleted their localized stores of ATP.
The cellular energy currency.
Exactly.
So the neurons haven't died. They literally just lack the chemical fuel required to fire another action potential.
Precisely. The sodium-potassium pumps within those specific neurons just can't reset the cellular membrane without ATP. So the neurons go entirely offline to manufacture more energy.
That's incredible.
And the diagnostic pearl here is the timeline. Todd's palsy resolves completely. Usually within a few hours, though, it can take up to 24. Because there's no structural tissue damage, once the ATP is replenished, the limb functions perfectly again. An ischemic stroke deficit does not spontaneously clear that rapidly or that cleanly.
That is brilliant. The limb goes offline because the local circuitry tripped a breaker, not because the wire was actually cut. Okay, so we've mapped the massive generalized grid failures. But I want to pivot a bit to seizures that isolate very specific physical mechanics. We have semiologies in the source material that manifest as either instantaneous extreme tension or a sudden total void of it.
the mechanical opposites.
Right. Let's look at myoclonic versus atonic seizures.
These present completely different observational challenges. So, myoclonic seizures are characterized by sudden, shock-like contractions. They are exceptionally fast, sometimes lasting only milliseconds, and they often violently recruit the axial and appendicular musculature.
Here's where it gets really interesting for me, because I kept visualizing this through the analogy of a marionette.
Oh, that's a good visual.
Yeah, if the human muscular system is controlled by strings, a myoclonic seizure is like a puppeteer violently yanking all the strings upward at the exact same millisecond. The entire body just jerked. But then you have the atonic seizure, which is the exact mechanical inverse. I mean, atonic literally translates to without tone.
Right, the drop attack.
Yes. It's like the puppeteer suddenly letting go of the control bar entirely. The strings go completely slack, the muscles lose all tone simultaneously, and the body simply crumples to the floor. And looking at this from a purely mechanical standpoint, the atonic presentation seems infinitely more dangerous to the physical body.
No, it absolutely is, and that's primarily due to the total suppression of protective reflexes.
Because they can't brace themselves.
Right. If you or I trip and fall, our motor cortex instantly initiates a cascade of defensive movements. Your arms go out, your neck braces, you try to protect your head. In an atonic seizure, the motor cortex is essentially shut off.
So they just fall.
The patient doesn't even fall, really. They are abruptly dropped by gravity with zero defensive posturing. The rate of severe craniofacial trauma associated with atonic seizures is remarkably high for this exact reason.
Yanking the strings versus dropping the strings entirely. It really reinforces how radically different these cortical misfires can manifest.
Very different.
And while we're on the topic of isolated motor patterns, the sources also heavily highlight epileptic spasms.
Yes, epileptic spasms have a very distinct semiological signature. They involve sudden, well-sustained flexor or extensor movements.
Meaning what, exactly?
Meaning the head, trunk, and extremities rapidly pull inward toward the core, or they thrust outward. But the crucial pattern recognition detail here isn't just the movement itself, it is the timing.
Right, they happen in clusters, don't they?
Yes, they occur in tightly grouped clusters, very often upon waking. And from a diagnostic perspective, observing that cluster pattern in an infant is a massive red flag.
Because it points to something much more serious.
Exactly. It is the defining feature of infantile epileptic encephalopathies like West syndrome. These are severe, devastating developmental disorders. The presence of those clustered spasms tells the neurologist that the developing brain is facing a systemic, deeply disruptive, abnormal electrical network.
It points the compass straight to a severe underlying pathology.
It does.
Okay, just to close out the motor-heavy portion of the toolkit, the sources also differentiate a tonic-only seizure, and that is essentially just phase 2 of the generalized storm we talked about earlier, the massive rigid spasm, but occurring in isolation without the rhythmic clonic jerking or the preceding aura. Is that correct?
That's absolutely correct. It is a massive excitatory surge without the subsequent inhibitory cycling.
Okay, we've spent a lot of time analyzing highly dramatic, visibly undeniable motor patterns, things that, demand immediate attention. But let's circle back to the scenario from our intro with the child and the pencil.
The subtle ones.
Right. We need to calibrate this toolkit for the virtually invisible misfires, because some of the most critical semiologies require an entirely different level of observational vigilance from you.
Right. We are moving into the realm of absent seizures and focal seizures.
Let's start with absent seizures, because mechanically they just fascinate me. Visually, it is the anti-seizure. A behavioral arrest lasting maybe 30 to 60 seconds. There's no motor phenomenon, no aura, no yanking or dropping of the strings, just a total pause in conscious activity.
The child simply stops. And the underlying mechanism here is entirely different from the cortical storms we've been discussing. Absent seizures originate in the thalamocortical circuits.
Okay, so what does that mean in plain English?
Well, the thalamus, which acts as the brain's central relay station, gets locked into an abnormal rhythmic oscillatory loop with the cortex.
Oh, so it's not a surge of destructive energy. It's more like a signaling loop that just hijacks the brain's bandwidth.
Precisely. The circuitry is essentially stuck on hold. The patient isn't unconscious in the way a syncope or a tonic-clonic patient is unconscious. Their awareness is just entirely suspended by this rhythmic thalamic looping.
Just pause.
Yes. And once the loop breaks, the circuitry resumes exactly where it left off, which is why there is absolutely no postdigital confusion. They just blink and continue writing their sentence.
Which completely explains why they are so wildly underdiagnosed. I mean, if you aren't trained to spot a thalamocortical loop, you just diagnose the kid with a fleeting attention span.
Happens all the time, sadly.
Now let's contrast that global pause with localized faults. Focal seizures. These arise from very specific limited networks in one hemisphere. And the sources divide these into two distinct categories based entirely on one variable, which is the preservation of consciousness.
Right, simple partial versus complex partial seizures.
So in a simple partial seizure, consciousness remains totally intact, which from a diagnostic perspective must be incredible. You have a patient who is actively experiencing a localized cortical misfire, but because their wider cognitive networks are untouched, they can literally sit there and narrate the event to you in real time.
The clinical history you can extract from a simple partial seizure is unparalleled. The patient can articulate the precise sensory or motor progression.
Like tracking the electrical spark.
Yes, they can tell you, the tingling started in their right thumb and then it moved up the forearm, and it was accompanied by the smell of burning rubber. That sequence allows us to map the electrical discharge as it literally marches across the homunculus in the somatosensory cortex.
That is wild. But that level of clarity disappears when we cross into complex partial seizures, doesn't it?
It does. Here, the localized misfire actually disrupts the networks responsible for awareness. So the patient isn't totally unconscious, but they are completely disconnected from their environment. And this is where we see the emergence of automatisms.
Automatisms, and those are semi-purposeful, repetitive motor behaviors, right? Like lip smacking, swallowing, picking at clothing, or pacing around.
Exactly. The patient appears to be engaged in a deliberate action, but if you try to talk to them, they are entirely unresponsive.
It's like the brain's higher executive function has just gone offline, so the lower motor systems default to a basic behavioral loop, like a computer executing a background script when the main operating system crashes.
That's a great analogy.
And there is one specific variant of these complex partial seizures that the sources highlight extensively, mainly because the semiology is just profoundly strange, and that's temporal lobe epilepsy.
Yes. When a complex partial seizure originates in the temporal lobe, the clinical presentation gets deeply complex. The temporal lobe houses critical structures for memory, for emotion, and for sensory integration.
So it's not just a physical twitch anymore.
Right. The misfire doesn't just produce a motor symptom, it produces profound cognitive and psychiatric symptoms.
The sources list these vivid visual or olfactory auras, bizarre posturing, but the defining signature, the one that really stops you in your tracks, is the spontaneous generation of déjà vu.
It's fascinating.
That overwhelming, unshakable conviction that you have lived this exact moment before. And when you actually look at the biological mechanism behind that, it is legitimately unsettling.
It really reveals how much of our reality is just a fragile construct of timing. So the hippocampus, which is located within the temporal lobe, acts as the brain's archivist. It receives incoming sensory data from the present moment, and it encodes it for storage.
It files the memory away.
Right. But during a temporal lobe seizure, aberrant electrical discharges essentially hijack the hippocampus and the amygdala.
Wait, so while you were looking at a room for the very first time, the misfire causes the hippocampus to instantaneously misfile the current sensory input into the past memories cabinet.
Exactly. The circuitry responsible for the feeling of familiarity is artificially triggered by the electrical surge. So the patient's conscious mind tries to rationalize this profound neurochemical signal of familiarity, and that results in the overwhelming illusion of a memory.
That is mind-blowing.
And it acts as an incredibly precise diagnostic beacon for neurologists. That specific sequence, so an olfactory aura, automatisms like lip smacking and intense déjà vu, that points a glaring neon arrow directly at the mesial temporal lobe.
But why is pinpointing that exact epicenter so critical? I mean, why not just treat it systemically with medication?
Because for many of these patients, these focal seizures are refractory, meaning they do not respond to anti-epileptic medications. And in those cases, the only viable cure is surgical resection.
Physically removing the tiny locus of misfiring tissue.
Right. And to do that safely, without damaging healthy cognitive function, the surgeon needs exact coordinates. The patient's semiology provides the map to that localized grid fault.
But the danger with a focal fault is that it doesn't always respect its boundaries, right? The sources mention secondary generalization.
Yes. A focal seizure can recruit adjacent tissue. If that temporal lobe discharge generates enough amplitude, it can actually overcome the surrounding inhibitory networks. It crosses the corpus callosum, floods both hemispheres, and cascades right into a generalized tonic-clonic seizure.
So a secondary generalization is basically just a simple partial seizure that managed to break containment.
Very much.
The single-blown transformer in the temporal lobe surges and takes down the entire continental grid. And once that happens, you are right back at phase 1 of the classic progression: the pallor, the rigid laryngeal spasm, the clonic jerking, and the whole metabolic crash.
The clinical presentation of the massive storm is identical. The only difference is the origin point.
So what does this all mean? Let's step back and look at the whole board here. We promised you a practical pattern recognition toolkit today, and hopefully you now possess one. You know that the shrill cry of a tonic-clonic event is a mechanical reality of air and muscle, not a conscious reaction. You know, to watch the clock for Todd's palsy, distinguishing temporary metabolic exhaustion from a permanent ischemic stroke. You can differentiate the violent neural yanking of myoclonic shocks from the highly dangerous gravity-driven drop of an atonic seizure.
Absolutely.
And you understand that a 40-second blank stare might be the thalamocortical loop, and that complex automatisms or spontaneous déjà vu are a map pointing straight to the temporal lobe.
And the true value of synthesizing this information is that it replaces panic with purpose.
I love that.
Yeah, if you are ever in a position to witness one of these events, you're no longer just a terrified bystander. You are an observer reading a neurological map. By recognizing the sequence of the aura, the motor progression, and the postictal recovery, you provide emergency physicians and neurologists with the exact data points they need to trace the electrical fault back to its source.
It literally turns observation into actionable medicine. Keep that toolkit sharp. But before we wrap up today's deep dive, I want to leave you with a final thought to mull over based on those temporal lobe mechanics we explored earlier.
Oh, the déjà vu mechanism.
Yeah. We established that an errant electrical surge in the hippocampus can spontaneously generate the profound, undeniable sensation of a memory that doesn't exist, or the smell of a fire that isn't burning. It really forces you to ask, how fragile is our baseline perception of reality when our absolute conviction in what is happening around us can be completely rewritten by a microscopic spark of rogue electricity?
It really forces us to realize that our conscious experience isn't a direct window into the world. It is a heavily filtered projection. And today we've seen exactly what happens when the projector malfunctions.
Well said. Keep observing those patterns, everyone. We'll catch you on the next deep dive.